He's one of the original members, which I am also a member of the California Mental Health Spiritual Initiative, which has been a statewide organization for the last 13 or 14 years. I can't remember exactly when it started, but he definitely is a founding member and also has been doing teaching spirituality and mental health for 30 years or so. And I just want to just say, from the first, he published over 80 articles on spirituality and mental health, and is an active workshop presenter internationally. And he's talking to you from Germany, I want you to know. And in spiritual competency, grief, health, recovery, and spiritual crises. He is a professor emeritus of psychology at the Institute of Transpersonal Psychology in Palo Alto, California, and previously served on faculties of Harvard and UCLA. He has his own experience. He does have lived experience, and I'll let him talk about that now. So it's my honor to introduce you, David. You're on. Okay.
Thank you, Wes. And it's good to see some familiar faces here because we're all involved in this effort to bring spirituality and mental health closer together. Certainly what got me into this area was my personal experience in my early 20s of going through a 2-month-long episode where I was holding the belief that I was a reincarnation of Buddha and a reincarnation of Jesus Christ, and I was writing a new holy book to change the world, and was in that state of mind for about 2 months, and was very lucky that during that time I had friends who took care of me, let me stay with them, so I never ended up on the streets. I was never hospitalized, and I was allowed to go through that experience. And certainly part of my work in the world has been to talk about what a spiritual crisis is, and how many people who experiences similar to mine can go through them without the need for psychiatric hospitalization and medication, as long as they're in a kind of a sanctuary environment where they're allowed to work with their experience. And there have been some programs like Soteria and Diabasis and so on that have allowed people to go through that. And the research shows that about half of people who have experiences similar to the one I had will emerge on their own without hospitalization, without medication. So that has been a primary niche of mine. And that led to some work I did on spiritual crises and DSM category that I'll talk about. But today, my focus is going to be on some of the areas that this experience has led me, which is to work with the potential for much more productive collaboration between religious professionals and mental health professionals. And I'm going to talk mainly about two examples, one of which is an experience Wes alluded to with the Mental Health and Spirituality Initiative here in California. And then I want to talk about another model of collaboration that actually is based in New York City and has spread out over the country. So let me go ahead and start with my PowerPoint. Okay, So it's nice to see that there's been a series of several presentations that I'm following that are building, that I hope to build on. And let me just mention that the majority of people, when they experience a mental health crisis, first go to their to a member of the clergy. That 4 out of 10 Americans, that's where they turn to first. And there's been research, for example, after 9/11, it was the clergy who were swamped with people with their concerns, more than mental health professionals. And clergy see more people than psychologists and psychiatrists combined who have a diagnosis of a mental disorder. Now, despite that, one of the gaps in the system has been the lack of collaboration between people experiencing a mental health crisis who seek help from the clergy or who seek help from a mental health professional, in people bringing them together. And in a study I conducted of Medline case reports, including religious and spiritual issues, only 12% actually included mention of a religious professional. And of all these cases, and there were over 500, only 2% indicated any collaboration between healthcare and religious professionals. And so I'm going to talk a little bit about why there is this gap. And there's actually issues from both professions that have led to this division. One is that psychology has historically pathologized religion. And Freud, who has to be given a lot of credit, he really did create this whole model we have now of therapy that, what was called in his day, the talking cure, that actually people can benefit from talking through their issues and their problems. Yet he, wrote a whole book about religion where he described religion as a system of wishful illusions together with a disavowal of reality, such as we find nowhere else but in a state of blissful, hallucinatory confusion. He also actually talked about religion as the enemy. And he was not the only person in the mental health field who did this. Many of the famous names like B.F. Skinner also pathologized religion, and Albert Ellis, who's the founder of the cognitive part of cognitive behavioral therapy, also pathologized religion. So if the pioneers in the field of mental health have all held that kind of a negative attitude about religion. And this is a cartoon of a Freudian-like character looking at meditating Buddha and describing him as an overprotective father, displays obsessive compulsive behavior patterns, possibly catatonic. And that is actually what the literature on meditation talked about, that was published in psychology journals. Up until the last 10 years, when mindfulness has now demonstrated its clinical value, if you look at how meditation was described in psychology journals in the 30s, 40s, 50s, 60s, into the 1970s, it was always pathologized as a form of catatonia. Another barrier to collaboration has been that in comparison to the general public, psychologists, psychiatrists, social workers are far less likely to affiliate with any organized religion. Now, that's not true of nurses, interestingly, but it is true of psychologists and psychiatrists and social workers. And then psychologists, even who are baby boomers, whereas most baby boomers have increased religious affiliation as they have grown older, mental health professionals have shown a decrease in religious affiliation as they get older. So that has created another kind of a gap. Now, I want to mention that there have been some changes. Well, the numbers aren't showing up here, but one of the, I think, drivers of a change in the receptivity of mental health professionals to religion is the fact that there's been much more research conducted on religion and mental health. And that graph there showing on the left, even though it's yellow and you can't see it, from 1970 to 2020, there has been a dramatic increase in the number of research articles. And for the most part, they have shown that patients, that mental, it's not showing up. Anyway, my point was going to be that the research has definitely demonstrated that for the most part, religion has been a positive force for health, mental health, that people who are members of religious organizations, churches, synagogues, mosques, and so on, have get social support, have a lower incidence of substance abuse problems, lower rates of depression, and so on. So that has convinced, for the most part, the mental health field that actually religion should be viewed more as a resource than as a type of pathology. I think another factor has been that the Joint Commission on the Accreditation of Healthcare Organizations, which accredits all hospitals, both physical, medical hospitals, and psychiatric hospitals, now actually requires that there be a spiritual assessment in every patient's chart. And they specifically say that patients receiving treatment for emotional and behavioral disorders, and patients receiving treatment for alcohol or drug dependence, and parents who have experienced loss of a fetus, and patients receiving care at the end of life need a more thorough spiritual assessment in their charts. So that has meant that even psychiatric settings and medical settings, which have, for the most part, unless they are specifically affiliated with a religious institution, and there are many, for example, hospitals that are run by Catholic organizations and so on, and they have always conducted spiritual assessments, but other medical facilities have generally not. And now they are required for accreditation purposes to include a spiritual assessment in every patient's chart. And that has been a game changer. Another, I think, factor that has been a game changer is that in 1994, the Diagnostic and Statistical Manual, which is kind of the Bible of mental health, included a category, and I was one of the people who authored this category, started to include religious or spiritual problem as a diagnostic category. And partly because it comes up a lot in mental health settings. And so including it as a category now means that everybody who trains to be a psychiatrist, psychologist, social worker, counselor gets exposed to religious and spiritual problems. as part of their training. And that was not true, for example, when I was in graduate school in the 1970s. In fact, I was literally told in my training that if a client wanted to talk about a religious issue, that my response should be to refer them to a religious professional. I should not engage in any discussion with a client about religion or spirituality. And now we know that actually some clients will specifically seek out a mental health professional, a psychologist or a social worker, to talk about a religious issue, because maybe they're having an experience of questioning their faith and they're hesitant to talk about it with their pastor or rabbi or whatever, and they want to talk to somebody they see as more neutral. So actually, mental health professionals do see clients who want to talk with them specifically about religious and spiritual issues. So there are also some obstacles to collaboration from the religious organizations and professionals. In their own communities, some congregants believe that they will be judged and rejected by their fellow congregants if they share mental health problems. Some have reported that their own clergy discourage them from seeking mental health care. And in treatment, some people report that they hesitate to discuss their personal religiosity as they've encountered mental health professionals who are not supportive of the role that religion and spirituality plays in their lives. So there's been many obstacles to collaboration. So let me talk about two I'll call them models. Models not in the sense that they are the best examples, but they are two examples of ways in which mental health professionals and religious professionals have successfully collaborated. And one is this group that Wes mentioned, the Mental Health and Spirituality Initiative that we were involved with for, it's now been about 15 years. It was actually initiated by somebody, and I'm sure some of you will know this name, Jay Mahler. He was one of the real pioneers in this field. He was actually a mental health consumer. And actually back in the 1970s, he started to lead groups in San Francisco for consumers to be able to talk about their religious and spiritual issues. And this is a quote of his: "My being aware that I'm on a spiritual journey empowers me to deal with other enormous parts of the puzzle, the big human spiritual questions." So he was saying that actually people who are mental health consumers are on a spiritual journey, and that has really not been acknowledged both in the mental health field nor often in religion and spiritual domains. And he was a very savvy person who realized that when in November of 2004, the California voters passed Proposition 63, which is called the Mental Health Services Act, that it provided some increased funding to support county mental health programs, and that could support some work in this area of integrating spirituality and mental health. So he pulled together a group of us, and we started to meet once a month. And it was a group of consumers and mental health professionals and faith leaders. And, we spent a lot of time getting to know each other. sharing our personal experiences. Many of us, as I mentioned, had both lived experience as well as deep spiritual beliefs. And based on our work together, we developed a proposal to get some funding from this Proposition 63, and were successful. And Jay Mahler was really the mover and shaker in this work. And we got funding that supported initially one conference, and that's what I list here because that's what we proposed. Since then, we have done actually 2 additional conferences, and I'll be talking about the role that conferences can play in fostering collaboration. It also supported some research, and research, in terms of changing the mental health field, that is an important factor. When there's good concrete research demonstrating the efficacy of delving into spirituality, that can be very persuasive for mental health professionals. And we did a survey both of consumers that I'll talk about and of county mental health directors. And then we also conducted a number of community dialogues that brought together consumers, faith leaders, and mental health professionals. And we also developed some training curricula in this domain. So let me talk just a little bit about some of the research. And this was one of the articles that we published on integrating spirituality and mental health, perspectives of adults receiving public mental health services in California. And it was published in a journal of the American Psychological Association, which has a lot of credibility. And this is from that research. So we conducted a survey of over 2,000 consumers. And when they were asked to whether spirituality is important to their health, you can see on the right that over 80% either agreed or strongly agreed that spirituality was important to their mental health. And here you can also see that about 88% agreed that mental health care providers should be willing to discuss spiritual concerns with them if they or their family request it. So this really revealed a kind of need that consumers have to talk about their religious and spiritual concerns. And another thing that our survey showed is that many consumers engage in spiritual practices. So at the very bottom, you can see that out of our 2,400 consumers in our sample, 1,900, so 75% engaged in prayer, over half engaged in meditation, about half engaged in what could be called a spiritual activity of spending time in nature. Singing was also, which can be gospel choir singing, but it can be just singing. But these are activities that many of them found helpful to their mental health. So again, this demonstrates that mental health professionals need to pay attention to these kinds of spiritual activities that mental health clients engage in. Then we also did a survey of mental health directors. And when we asked county mental health directors to rate whether they considered spirituality to be an important wellness resource in mental health prevention, you can see that over 94% agreed that spirituality is an important wellness resource for their clients. And certainly one of the pioneers in this is Marv Southard, who was then director, he's now retired, of the LA County Department of Mental Health. And basically his stance in taking the LA County Mental Health Department into addressing spirituality was that, quote, anything that supports hope, wellness, and recovery is something that a public mental health system ought to do. So he made LA County into one of the model counties for integrating spirituality into their mental health care. And I know I did three-day trainings with over 800 of their staff. And we provided training in how to conduct a spiritual assessment, how to be sensitive to consumers' religious and spiritual beliefs and practices, the value that spirituality can play in their lives, and so on. So I conducted over 15 of these mental health and spirituality 101 trainings. I'm going to give an example here of one I did for Faith Leaders. We conducted similar programs for mental health professionals, but since my understanding is that I would be addressing both faith leaders and mental health professionals, I'm going to share a little bit more about what my training for faith leaders was like. But it was similar when I conducted these trainings for mental health professionals. So first of all, for faith leaders, one of the things that was important to point out is how common mental distress is. That it's actually people experiencing mental health problems is actually more common than cancer, diabetes, and heart disease. That psychiatric disorders are the #1 reason in the United States for hospital admissions, and that nationwide, 1 in 4 adults experiences a mental health disorder in a given year. And often when I've done these trainings, I've asked the faith leaders in my audience, how many of them have actually received training in how to address mental health problems? And by far, the majority of faith leaders have reported that no, they really haven't received any real training in how to address mental health disorders. Even though some surveys have shown that that many faith leaders are spending over half their time in counseling sessions with couples who are having marital problems, people who are having substance abuse problems, people coming back from the military, Iraq, and so on, with mental health problems, situations they were actually not trained to deal with. So just, a list of kind of what are signs of mental distress: changes in mood, sensations, irrational or nonsensical thoughts, bizarre behavior, impaired intellectual abilities, sometimes related to depression, withdrawal, loneliness, and isolation, often frequently associated with depression. And then in my own trainings, if I was given a good chunk of time, like 3 hours, I would then go through a summary, and I'm just going to give you an overview of it, of what are the primary types of mental distress. And this would be just an overview, just so that we are on the same page when it comes to terminology. Mood disorders. What is a mood disorder? What are we talking about? What is a psychotic disorder? What is a personality disorder? You know, what do we mean by an eating disorder? So I'll just give a little overview here of what I would cover, for example, with regard to depression. What are the signs and symptoms of a depressive disorder? So one of them is negative thinking. I can't, I won't. Negative thinking about oneself. I'm a sinner, I'm a bad person. I've ruined my family's life. I'm not supporting my family. Another very common depressive symptom is social withdrawal. These kinds of people might stop coming to church, even though that's a major source of social support for many people. Irritability, you know, breaking out and yelling at their family, maybe even at their clergy member, you know, their faith leader. You know, if it's a teenager, poor school performance and so on. Okay. What are the, so those are the symptoms. And yet 1 out of 4 women and 1 out of 10 men will develop a depressive disorder during their lifetime. Yet fewer than half ever seek treatment. So that's just one of the examples. I mean mental health treatment. Many of them who do not seek mental health treatment will seek out a member of their clergy to talk about these issues. And then I will, if I was giving a longer presentation to faith leaders, I would talk about how mental health professionals work with depression, the kind of psychoeducation, cognitive model, you know, how to work with negative thoughts. That's one of the primary treatments for depression is cognitive behavioral therapy, which includes when you have a negative thought, how to dispute it, how to debate with yourself. If you say something really negative to yourself, like I'm an awful person, to be able to step back from it and say, oh gosh, there I am, beating myself up again. I need to be kind to myself. I need to treat myself the way I would treat my best friend, my wife, my spouse. I shouldn't be, you know, so down on myself. So when you have a negative thought, how to debate with it. Also, to start scheduling activities if you're depressed, so that you don't just stay around home watching television, but schedule an activity like going for a walk or joining the softball team at your church. Become, you know, how to have a conversation, even when, you know, you're not really feeling like talking, but going ahead and developing your social skills. Exercise. Actually, the research shows, and I think even mental health professionals are often ignorant about this, that exercise is as effective as antidepressants in countering depression. So that's an important thing to know. You know, I think many churches now do have things like walking groups, softball groups, you know, things where yoga, you know, something to get people more physically active as an antidote for depression. So, but this is what a mental health professional would also do if you referred them to a mental health professional. And then I would also turn to, and then now I'm just going to list them because we're not going to spend a lot of time talking about each of these disorders, but I would move to bipolar disorder. And many of you, I'm sure, have already had an opportunity in your life to work with somebody who's experienced mania, where they're, instead of being depressed, they're euphoric. Or another sign of mania can be real irritability, agitation, and then anxiety is also another very common mental health problem. And we could talk about the different forms of anxiety, phobias, obsessive compulsive disorder, post-traumatic stress disorder, and so on. So as a mental health professional working with a group of faith leaders, I would want them to become familiar with this terminology so it doesn't seem like Greek, some foreign language. And, I think most mental health professionals hopefully would also be able to use everyday terminology, but this is our, just like plumbers have their jargon, for describing what goes wrong with plumbing. Mental health professionals have their jargon. PTSD, we now know, is very common amongst returning veterans. And I would think it's important for faith leaders to really understand what that looks like. Schizophrenia, and how that affects how people view the world, and what kind of treatments, what kind of medications there are for them, and so on. Okay, so one of the things that we did as part of this mental health and spirituality initiative was hold conferences that were open not to just mental health professionals, but also they were a model of, I think, this kind of collaboration, roughly. And a third of the people at this conference and at our other conferences were mental health professionals. About a third were consumers, and about a third were faith leaders. And we were all participating in this kind of shared learning experience to understand each other's roles, beliefs, and values in our shared work together. And this led to a number, I mentioned, California has about 60 counties, and I've provided these kinds of trainings in 15 of them. Spirituality, for the faith leaders, they were called Mental Health and Spirituality 101 trainings. And for mental health professionals, they were called Spirituality 101 trainings. And for example, this was one that I gave in Solano County. And one of the foundational skills that I have focused on in this area for mental health professionals is how to conduct a spiritual assessment. And I have worked on a spiritual assessment format that I have taught in these programs, and I've now developed into an online course. And it's available online, and it's actually available for free. It's available for continuing education course. There's a fee if you take it for CE credit, but the whole course is available for just taking for no cost. And it's an evidence-based, meaning research-based, ethically sensitive, meaning it's sensitive to people from any religious or spiritual or atheistic backgrounds as well. Many people who say they're atheists actually have a number of spiritual beliefs that can be addressed in this. And the other thing is that it's strength-based. So it isn't just focused on religious and spiritual problems, it's also focused on spiritual strengths. You know, what is a resource in a client's life when they're feeling down or depressed? You know, what is a resource for them? Is it going for a walk in nature? Is it meditating? Is it listening to gospel music? We as mental health professionals should know what is a resource for them. So that's what we've done in California. Let me go ahead now and talk about another model of collaboration that's called the COPE program. And there have been a number of articles published by Glenn Milstein on this model, and COPE stands for Clergy Outreach and Professional Engagement. That's what the COPE stands for. And two central ideas that guide the COPE program are that clergy have discrete expert knowledge about religion, and clinicians have their discrete expert knowledge about mental health care. And that it is when people collaborate that they can help a broader array of persons with emotional difficulties and disorders through the collaboration. So let me talk a little bit about this COPE model. And one of the findings is that many clergy have been hesitant to refer to mental health professionals who are outside of their religious values. In other words, some of the literature would say things like a member of the Catholic clergy who was dealing with a client who had a mental health problem should refer to a mental health professional with a shared background, shared values. And actually, there have now been some studies that have rigorously compared the work of religious psychotherapists with the work of non-religious psychotherapists in treating religious Christians. And there's the reference of one of the studies. And this study found that non-religious therapists providing religiously informed psychotherapy achieve the best clinical outcome for religious Christian patients. And that religious therapists providing non-religious psychotherapy achieve the next best outcome. So what that research, the importance of this research is that it shows faith leaders that they can feel comfortable in making referrals to mental health professionals who do not share their core religion. So a rabbi can make a referral to a mental health provider who does not share their Judeo background, Jewish background. Okay, so this is the COPE model that they developed, and it's really based on prevention science. There's a whole literature on prevention that they drew on, And let me explain what this chart is showing here. First of all, you'll see there's four hexagons, and as you go from the top around the circle, they get smaller. So the first is the universal, which is for religious organizations, congregations, that they really provide a very core prevention input that people often, by going to their religious organization, church, synagogue, temple, whatever, are provided with resources and resiliency. So the first hexagon there comes from the benefits in preventing mental health problems of attending a religious congregation. Then to the right, when members of a congregation are under stress, job loss, bereavement, natural disaster, that often it's their congregation that helps them through it, through some of the beliefs, biblical study groups, brief clergy counseling, social support, hospital visits, and so on, that they can actually prevent the occurrence of a mental health disorder through their attendance at and participation in a congregation. Okay, then when you hit the third hexagon there, that's when there is some mental health distress. Depression, anxiety, something that is actually reduced, some form of impairment. That's where there is an opportunity for clinicians and mental and faith leaders to start this process of collaboration. And it can involve consultation with clergy, collaboration with clergy, and so on. And that's usually somewhat time limited. These are situations where somebody goes through a depressive episode, maybe bereavement. Bereavement is actually probably the most common, when somebody loses a life partner, and they can go into a phase of bereavement that, if it's not addressed as bereavement, can become depression. But often a faith leader working in the congregational setting can prevent the occurrence of a mental health problem through this kind of collaboration. Then the fourth one on the left in this image is for somebody who actually does have a mental health disorder. And part of it now is preventing a relapse. These might be people who are on antidepressants or anti-anxiety medication, who can actually be maintained, maybe with some therapy and medication, and you can prevent hospitalizations, relapses, and so on through this kind of collaboration, or what they call collaborative recovery. So this is a model that was developed in the COPE system so that mental health professionals and faith leaders can kind of be on the same page about what their mutual roles are in preventing the occurrence of more severe mental health problems. And this was one of the handouts they provided for faith leaders. And this is just to acknowledge from the get-go for faith leaders and acknowledge, what they are already doing. That you, faith leaders, are providing comfort, support, meaning, which can foster positive psychological attributes. We often use the word resiliency now, hope, perseverance, and happiness that can prevent mental health problems. You provide religious coping beliefs. Religious coping is one, there's now a wealth of literature and books on religious coping and how important that is in preventing mental health problems for many people, that they will turn to their faith when they're experiencing loss, and they'll find some coping strategies within their faith tradition. It may require some of these other things like reintegration. If they've gone through a depressive episode, maybe they've isolated themselves, and it may require the faith leader to help them reintegrate into their congregation. So this is one example from this COPE program. That was started in New York City, and what they did in this mental health program was at the hospital, the psychiatric hospital, they turned to their Department of Pastoral Care and Education in their hospital, and they presented a grand rounds. So that's where, mental health professionals typically come to grand rounds, and they had their pastoral care and education department present at their grand rounds to the mental health professionals. So it put the faith leaders in the role as the experts, and they presented practical models for clinician and clergy collaboration. And this was called InReach to mental health professionals, because it was done within the mental health setting. But they integrated the pastoral care and education department. And it led to the development of religiously inclusive intake questions that they added to their assessment, to their intake assessment, that was conducted typically by social workers. And it also led to chaplains providing more information to the hospital clinicians about any of the problems they were looking at. So that's what's called InReach. In other words, the mental health system looked within themselves and brought in clergy and other people to present to mental health professionals.
Dr. Lukoff, could you wrap it up in about 2 or 3 minutes? We're getting close to the 10 o'clock hour.
Sure. Okay. So one of the points was just to show that this is, we have a long history of religion being part of healthcare in our shamanic traditions and so on. This is a Navajo healing ritual. But, you can go back to Greece. The temples in Greece actually provided healthcare. And the first hospitals were all part of religious institutions. They were part of churches. Okay, so the clergy outreach then included some programs like I described, which were for faith leaders to acquaint them with mental health terminology and so on, so it wouldn't seem like Greek to them. They hosted a half-day symposium on mental health and invited Muslim, Orthodox, Jewish, and Jehovah's Witnesses to the hospital so that we could start this dialogic process. Okay. And just to point out that this is one cartoon that shows that when you start opening up church settings to, for example, one model was in one hospital, in one church, they started to encourage parents who were not bringing their children to services because their children had ADHD and would run around. And sometimes clergy would tell them, oh, no, that's too noisy. You can't bring your kids to church. And now there's been this focus on, no, bring your kids to church and we'll deal with some of the outcomes like the church sweltering in July heat due to a little boy's curiosity and turning off the air conditioning. Okay, so I think I can pretty much leave it at that to just show that there are models of collaboration for mental health and faith leaders.
So thank you so much, Dr. Lukoff, for such a rich presentation. I did spend some time looking at some of the articles in our previous series, and they're very rich, and even some of the videos that we have online. So thank you so much for coming all the way. Well, you can come, but presenting all the way from Germany today. So my name is Arnold Fossa. I put my name in the chat, but I'm a psychiatric nurse practitioner employed with the county in private practice, and I do some work with nonprofits, FaithNet as well. I've been in collaboration through this series. And today is our, we know it's our fourth session, and have the pleasure of not only having Dr. Lukoff here, but a number of other faith leaders and practitioners, and I think we have one consumer in our midst today. So I'm just going to go over briefly the notes. We have Alicia Lee. I want to make sure you forgive me if I don't pronounce names correctly or if I leave out anyone, but I think we have Alicia Lee, who is a clinician. We have Rabbi Lisa Delson, and we have Alex Senegal, case manager, and Reverend Etsuko Mikami, who is, I think she's a Buddhist leader or practitioner. And I think we have Diana. I was looking at at those who were here, and I didn't notice any Diana. I don't know if she's here, but she's also a participant. And I would encourage you to say a little bit more about your background and what you do and how you came to be doing this valuable work with spirituality and mental health in your intro. Some of the questions we would hope you would address today are how you'll, as a provider or a client or faith leader or a peer or mentor, how, as in your role, how do you incorporate spirituality and faith in treatment or recovery of yourself or your clients or your congregation? So I want to hear about that. And then also we want to hear testimonials from you guys about what you see happening in your either private practice or in the congregation. So I don't know if Alicia Lee,
yes,
you do us the honor of leading. Thank you very much.
Yeah. So how long do I have? Because I tend to go long-winded. So I have
okay, so that's good. I'm glad you asked. So we have 10 minutes.
Okay.
And there will be time for questions at the end. So I would encourage folks to put in questions at the as we go along. Even for Dr. Lukoff, if we can please just put the questions as we go along. and then we can go through some of those questions. If we can get through all of them, it'll be great. So thank you.
Yeah. Okay. So my name is Lisha Lee. I started my career actually in New Jersey and New York. So I'm licensed in New York and New Jersey and California. So my first actually job started in the psychiatric hospital, but it was a Christian psychiatric hospital. If I think I saw somebody from New Jersey, they will know it's a Ramapuri Psychiatric Hospital in Lukoff. So I was so lucky. I was landed their internship and they hired me. So I was working very closely with the chaplains, and our department was closely connected to the chaplains department. So there I was able to do group therapy and individual therapy. And also I was able to do the Bible study, whoever comes. So, and I was able to do the chapel on Sundays. So, it was in my mind always integrating the faith and mental health was always from the beginning, because I went to school. It's Alliance Theological Seminary. It's in Nyack, New York. They have a counseling master's program. So I was I was in the program to become a pastor. Then while I was studying, then the counseling school opened up. So I switched to the counseling school. So I always had a heart for the pastoral care kind of thing. So that's, like 2000, so 22 years ago. So I was continued to work. So I was really informed about clinical illness, because working in the psychiatric hospital, that was a big plus for me. So distinguishing when the client comes, what is the immediate issue here, spiritual, or it's a combination, but you have to decide, which treatment you go first. So it was good because I working in the hospital gave me enough information, clinical. So 2008, I moved to California. So I was doing private practice, most of my client comes from my, the catholictherapist.com. So that's a faith. You see, my most of them is a Christian or Catholic, and some of them is not, because I get some client from the insurance. So I work with all across the border. And what I'm sharing today is not like a research base or anything like that. It's just purely coming from my personal experience, subjective information. So 2000, I started private practice here, and 2019, it's always in my mind to integrating faith to bring up deeper healing for people. So 2019. A few priests and few lay people, we started the healing retreat. So that healing retreat, we've been doing it 2019, 20, 21, 22. So almost 10 times. So there we integrate very heavily the faith and the healing prayer. And I found you see, my background is basically Judeo-Christian tradition. So, what I'm sharing is coming from that tradition. So I saw a lot of people who comes to the healing retreat that breakthrough I never experienced in the therapy session. Sometimes I get very frustrated with, I can take them to a certain point and I cannot take them beyond. But through this, connecting them in the spiritual realm of their life and connecting to the person who is infinite love, that just broke through people's lives. And then just which I couldn't break through. It's almost like a mystery. So when I experienced that, so I couldn't not do that. So my focus is mostly on the healing prayer and also scripture. And so I work mostly with people with a Catholic Christian background. And that's being said, because in my private practice, the people who comes to me with a different background, religious background, some are Buddhist, some are no religion, no faith background, but I can still work with them very well. So Buddhist background. So we had a great time because he knew I was Catholic, but we just share. I understand Buddhism, so letting go, surrendering. So we do that to, Christian faith to surrender. So we work together with this Buddhist client. So we work very well. I was very respectful of his faith, and he was respectful of my faith. But we found the common ground. So very effective. And there was an atheist client, no faith background. I can still work very well. I've seen her like few years. So we built a strong bond. She knew I was Catholic. She knew where I stand morally, ethically. And without saying name, this person is practicing transgender. So she understood I was Catholic. So she asked me, after sharing her transgender issue, she asked me, are you willing to continue with me? So, I said, yeah, let's think about it. I gave her 2 weeks, let her also think about it. So what she did was we thought, we think about it, and I also prayed about it, but we came to a conclusion, we will continue because I feel she needs that kind of love and acceptance, So we are so happy we're bonded. She hugged me, and then we continue with our therapy. Our relationship become even stronger, even the difference of belief and faith, because there was a common bond of that she felt I cared about her. So, so even though I have a Catholic background and I am open to work with many different faith, people with a faith, and it is effective. So just touching my work with recently the healing retreat is very focused on the childhood trauma. So recovering from the childhood trauma is remove a lot of big obstacles for their life in a current situation. So it is very effective. I will not go back to what I was doing, just a therapy, because I know this is so effective. Will I not do this? So that's the way to go. I'm, actually, I look younger than my age. I'm 70. So my future goal is to continue to integrate, where people are at, whether it's the same faith I share with them or not, so I can tap into their deepest longing. That's a spiritual. Yeah. I hope that's enough.
Oh, thank you so much, Licha. You shared something. Sorry, this is my. So thank you for sharing that. What I picked up was the key universality in our spirituality, and your willingness to kind of go beyond just your congregation or the people that you are familiar with. I think there is that sense too, that as we're being introduced in this area, that it's for everybody. It's not just for a narrow set of our congregants. So let's go ahead and have, is Diana here? No, let's go ahead with Rabbi Lisa Delson, please.
What was this? Arnold, I was trying to text you, but Adrian, would you like to present about yourself? I think, she's just as important in this.
I'm sorry. I'm sorry, you said Adrian?
Adrian Hammond.
Okay, so since I already called on Rabbi Lisa, let's go with Rabbi Lisa for now, and then we'll get Adrian later.
Okay, thank you.
Morning. I'm Rabbi Lisa Delson. I'm the Associate Rabbi at Peninsula Temple Shalom in Burlingame. And thanks to Bill for inviting me to be here this morning. So My background is I am a rabbi, a Reform Jewish congregational leader, and I was ordained at Hebrew Union College Jewish Institute of Religion in Cincinnati, Ohio in 2009. And I've been here in the Bay Area since 2014. And my congregation is in Burlingame. And for a long time before I got here, and still, but we're working on it, talking about mental health was not something that our congregation talked about on a wide scale. It was something that we knew everybody had some sort of touch point with, but it wasn't something that people felt comfortable talking about. And in 2014, as a congregation, we embarked on a community organizing campaign in the congregation. So having small house meetings and larger congregational gatherings to figure out what is on people's minds and where are people. And one of the things that came up over and over and over was a concern about teen mental health. And it just so happened that around the same time, unfortunately, one of our teenagers, a 15-year-old, died by suicide. And as a result of that, it sped up our decision making on what we were going to focus on as a congregation. And so we jumped in and we created a 3-prong approach to dealing with mental illness. First was education, second was advocacy, and the third was just in general talking about the stigma of mental health. And so from 2014, we've had a variety of programming and conversations within the congregation, and it's changed and grown and moved since then. And what it first started as was this initiative called Panim El Panim, which in Hebrew means face to face. Well, it's in Hebrew. In English, it's face to face. And how it came out was that we actually were talking with our youth group, and a 16-year-old who was the president of our youth group at the time, she said, what I really want to know is how to talk to someone face to face who is dealing with mental illness. She said, we all know someone who's depressed or who has anxiety, but we don't know what to do. And so this sparked this idea of Panim El Panim, which comes from the Torah, from the Hebrew Bible, where Jacob wrestled with the angel in the book of Genesis, and he begged to see his attacker's face. And it was dark and he was trying to get his bearings. And this is exactly how our teens felt and feel when they're trying to help a friend. And so that's how we named our initiative. After that, we took our learning seriously. We hosted a half-day conference that included school officials from the San Mateo Union High School District, Dr. Stephen Adelsheim from Stanford, and offered our teens and adults an opportunity to talk about their experiences and think about what they might need from our community. And at the same time, it was already in the works. There was a $1.4 million budget for the high school district to include more mental health resources on school campuses. That we were in conversations with them at the time. At that time, what we did as a congregation was we added a Jewish social emotional unit to our 9th grade supplemental school curriculum. And we invited our teens to lead our worship services and talk with a mental health focus. And 5 years, I guess it's more than 5 years, we're still working on these things. It's really infused in whatever we do. We continue to hold a monthly teen workshop called Moving Traditions, where students signed up for a single gender group to discuss what they face. And it's not only about mental health, but it offers an informal Jewish space, and it's also fun. And we think that also contributes to their mental health. One of the things that came out of our initial initiative was a program called Let's Talk Mental Health. And this is where our reach expanded beyond what our teens were doing. And quarterly, we invited a panel or presentation to help those suffering themselves and those with their family members. And we learned about how law enforcement manages mental health in their work. We had a presentation on CBT and DBT. We heard from California Clubhouse. We learned from other faith traditions how they talk about mental health. And NAMI San Mateo supported us as well, and we supported them. And in the past month, we included programs with Josh Coleman to talk about family estrangement, a topic that plagues many of our congregants and is really so filled with stigma that people don't really have an outlet to learn or talk about it. During COVID, at the beginning of COVID, we called every member of our congregation, both clergy and lay leaders. And from there, we found out that people really wanted to talk with each other. And so we hosted a weekly conversation group to keep isolation at bay for our older members. Another way that we've kept this as part of our regular workings of the synagogue is every fall during our High Holy Days, which is a 10-day period of introspection, 2 holidays, Rosh Hashanah and Yom Kippur. This is a time when people look inward and try to repair their relationships with themselves and other people and with God. And during this personal introspection and pause from the rest of life, it offers us an opportunity to talk about mental health. And we do this on Yom Kippur afternoon during a service of renewal. And the service is based on the book of Jonah. And so after we read the book in 7 sections, we acknowledge the human experience, reconciliation, communal pain, caring for the spirit, mental wellness, caring for the body, and ending with gratitude. We also have a panel of congregants who talk about their life experiences. And over the past years, many of the topics have been related to mental illness and overcoming personal challenges. Our advocacy realm, which we don't imagine that we're going to have a huge impact on advocacy. We often sign on to letters for other organizations, but I think it's one of the ways that our congregants, at least whose family members are dealing with mental illness, it feels like a way to make change out in the world rather than just change in our community. And so in the past year, we signed on to AB 988, supporting the funding and access to 988, the emergency line like 911. And so we added our name to that as well. So overall, we try really hard to keep mental illness as something that we talk about, we recognize it, and we do what we can to reduce the stigma in our congregation, which I failed to mention is about almost 600 families.
Wow, Rabbi Lisa, thank you so much again for, wow, it seems like you're doing a lot of different things, and there's a couple of themes that I picked up on, one of which was just kind of listening and responding. That's kind of what I first you had the teenager, the unfortunate event, and then you kind of started responding, and then this story about I think Jacob seeing the face of someone. I think there's that sense about spirituality, or going to this intimate place of vulnerability and seeing someone and seeing the congregants' faces. And I think that's beautiful that you guys are responding in such a powerful way. So thank you so much for sharing that. I'll go ahead and switch to, I think Brother Wes mentioned Adrian Hament. Sorry if your microphone is muted. Let's have you on for the next 10 minutes, please. Your microphone is muted.
Okay, now you hear me. Okay, I'm Adrienne Hammond, and I'm from Los Angeles County. I just retired from the Department of Mental Health, and what David talked about, the initiative, he talked about the statewide work that he was involved in. I was involved in Los Angeles for practically 2 decades. And we did conferences, we did outreach, we did training to different church leaders all over the county. And we finally, after many years of training, we came up with the Mental Health Academy, which was really a series of trainings that we marketed to the different faith leaders and to the different communities. We no longer made it exclusive to the faith leaders. We opened it to everybody. And then I retired, and the department changed leaders, and the spirituality movement kind of moved into the back burner. And so now that I am retired, I have been helping pro bono the Archdiocese, the Catholic Archdiocese of Los Angeles, where they are thinking of creating mental health ministries in the different parishes. And when you talk about LA Archdiocese, you're talking about 3 different counties, Los Angeles, Ventura, and what's the other one? I think Santa Barbara, and so there are so many parishes to be worked on or to be encouraged to be involved in this. Well, one parish is in South Pasadena, and they have a new pastor who happens to be somebody I got to know at the Archdiocese. And he was the one who said to help him create this mental health ministry at his new parish. And so far, that meant 2 presentations that we have had, one virtual. And we found out that in that virtual presentation, we had less than 20 people in attendance, and most of them were adults and older adults. But when we did the same presentation, which was mental health in general, we did it in person, we had a bigger crowd, and it was more diverse. We had all sections, we have the elderly, we have the adults, and we have the young people, and we had one teenager, and we had couples, and it was more diverse. And so tonight, actually, we're going to sit down and talk about the next steps on how really to work this out, on integrating, on creating, on having a mental health ministry in the parish. And so that's where I am helping. I do both. In our profession, we talk about the micro and the macro. Micro is what Leisha was talking about, doing individual and group interventions or treatments. Rabbi talked about her changes in her synagogue, and that is what we call macro. And I am involved in both. I stopped doing private practice and some years ago, but I am now more involved in programming and resource finding, things like that. And so right now, at the presentation that we had, which was both virtual and in person, I made the mindfulness presentation. And it seemed that some people expressed their interest in that. And some people have expressed having groups where they would learn more mindfulness. And I figured that would be good. And that would also be good to talk about, meditation, to talk about the therapeutic techniques that we use that we utilize in treating some of the mental health issues. And so that's one avenue that I will advocate for. But then at the same time, I am also really looking at the we tend, and I say we, I mean the system, whether it be the government system or the religious system or the church system, we talk about mental health in general, but we don't really know how to do it programmatically. Do we just deal with, in the medical profession, the body has already been compartmentalized. You have the cardiologists, you have the neurologists, you have the nephrologists. So every part of the body has been specialized, and then it got to the point where you need general practitioners to take the whole body put together and be seen as one system. Now, in mental health, we look at, we don't know if we're going to, we also compartmentalized. We talk about the geriatric grouping, the geriatric group, the adults, the young adults, the Tay people, and then the children. And so now that I am involved on the church level, I begin to wonder, how do you approach it? How do you approach mental health? Do you approach it from, do you offer it, for teenagers only? The teenagers in our community, in this South Pasadena community, has a high incidence of suicide. And do you approach that alone? And then we have a grouping of the elderly. How do you take care of them? They are also concerned about suicide. I call it passive suicide, where the elderly begin to be isolated, and then they do not eat, they do not take their medication, they do not talk, they do not get out of their houses, and some of them are found dead, at home, alone. And so how do you deal with that? And then you have the adults. These are people who are still working. Some are married. Others are in non-married relations. Children are involved. So how do you work that out? It's so broad. And so for me, it's I am helping the Catholic Church, the Archdiocese, and then the two parishes that I am involved in. And I have more questions than answers. And yet at the same time, I'd say, there are some resources that maybe we can tap. And I don't know, but I still feel that there is a movement within the Catholic Church. It is now almost like an encouragement coming all the way from the top, which is the UCCB. That's the group of bishops that look at the whole Catholic Church in this United States, and they are the ones who a few years ago they sent out an encouraging idea of creating the mental health ministry. And I felt that, I said, my gosh, I'd say hallelujah to that. Right. Because finally I felt like the Catholic Church is waking up. This mental health ministry has been going on for almost 50 years in the Christian sections all over in the country. You have Pathways to Promise that has been going on, I think, for the past 50 years. And their role is...
So Adrian?
Yeah.
Adrian, so just in the interest of time, I have to just have you wrap. Go ahead and give you another minute.
No, that's just it. There are already people who have been involved in the integration of mental health and spirituality. And I just mentioned Pathways to Promise, which is based in Illinois. And they have been in existence for almost 50 years. And we can look at them and see their journey and how they have succeeded, and it's how and what challenges they have. San Diego has mental health ministries also.
Well, Adrian, thank you so much. I think one of the things I see you raising questions about is how do we do this, right? Because there's a macro and the micro picture. I really like that you split that up, but you're raising some really important questions. I think that's part of the reason why we're here, starting this conversation and seeing where it goes. And so we'll probably be looking to you as a resource later on to see if you've had those questions answered. Let's move on to Senegal. Alex, Senegal, please.
Yes, how you doing? First of all, I want to thank everybody for allowing me to be here. Wesley, I thank you for the invite. I'm Minister Alex Senegal. I'm a minister over at Bible Way Christian Center in San Jose. I also I run a reentry center. And I'm also involved with the Enneagram Prison Project. As you see behind me, my banner, I'm an ambassador. I'm on the board at the Enneagram Prison Project. And I'm also in the process of developing another reentry program with the Enneagram Prison Project. Just a real quick background on me, and so I get a good idea. I have over 26 years of incarceration. I came off of a life sentence in 2004, stayed out incarcerated free for over 10 years and went back into custody, went back into prison. Who does that? After going back to college, when I got released, I went to college, graduated, and I graduated from college, became a substance abuse counselor, became a mental health specialist, working over at the Salvation Army in San Jose. I also worked over at Gardner Mental Health, and I did real well. But what was my problem? What was the main problem? Well, the main problem is the only thing I could ever connect with was my destructive lifestyle. I was a drug dealer. I've been a gang member since I was 12 years old. I was an alcoholic at 5 years old. I grew up in a very, very destructive environment. And that was what I connected with. Even though I was doing good things in the community, became a court liaison, and I was doing all these positive things for other people. But what happened with Alex? Alex had no one to talk to. Alex couldn't connect. Like I couldn't connect with each one of you. I could be sitting here, I can listen to you, I can have a conversation with, but it wasn't inside of me, there was no connection. And so finally, after acting and pretending, I went back to what I connected with. Well, the best thing about that is that's when I was introduced to the Enneagram at that time. And one of the things about the Enneagram, if you have never heard about it, it's a 9-point personality tool. And the one thing that we focus on at the Enneagram Prison Project is what's good about you, not what's wrong with you. And so many times we're focused on what's wrong with me. What's wrong with me? And we're so focused on all the negative things about us that we are just not ever introduced to what is called true essence. I call it the true spirit of God that lives within inside of me. And so after doing all this here, I'm given this fantastic job, and I specialize working with people incarcerated or being released from incarcerated. I love being working with individuals that's released from incarceration, because what I get to do, I get to offer hope, help, and healing. I get to offer that. And I offer it in the way that I offer that, the way that I help individuals. Because one thing I know for sure, every person that has been incarcerated is suffering from trauma. It's all trauma-based. And I address the trauma because I have to address the trauma, because I had to address my own trauma. Once I did address my own trauma, once I got over and had self-forgiveness, once I came to overcoming the guilt and the shame that lived inside of me, I stopped going to prison. And now I am a well-productive member of this society. And I'm so thankful for being able to be here to share time with this community. And I'm looking to be a part of this community. And the things that I do that help individuals that I've learned has been very effective. I offer myself. I offer what is called the love of Christ. I am of the Christian faith. I offer the love of Christ, and I accept individuals and I help them discover what's good about them. You know, they come out of incarceration. Sometimes they see me before they go see the parole officer or the probation officer. And I help them really just discover, what's good about you, even if it's one thing, two things, or three things, or what's good, and let's focus on that. And then we'll start working on the self-forgiveness, and we start working on overcoming the guilt and shame. And so I develop a rapport with the individuals I work with to the point where they're willing to open up to me, and they talk to me about things they never talked to no one about. I mean, never talked to no one about. And they even say, they sit there and say, I don't believe I'm sharing this with you, because I just offer my heart, and I give the individuals my heart and just everything that I wish someone had gave me. Yes. And I give that to them today. And so right now, just last week, actually 2 weeks ago, last week I was in Sweden. I got to go to Sweden to look at the different environments of the prisons there and how they treat their prisoners there, as opposed to how we treat prisoners here in the United States. But 2 weeks ago, I was at R.J. Donovan, which is a level 3, level 4 prison down on the border of Mexico and San Diego. And we did a whole week's program in there. And I did to teach them about the Enneagram, to help them discover what's good about you or why we do what we do. And in that process, I remember walking into that prison on Monday, and I'm sitting here with a group of 66 men, and all I see is the darkness in their eyes. I see no hope whatsoever. There was no hope. And then after being introduced to them and they're introducing themselves to me, they've been down 43 years, 39 years, 32 years, 26 years. One young man, he was 32 years old. How does the individual who's 32 years old been down 26 years? How does that happen? He never got out. He was sentenced when he was a child, and he continued. He's never been in the community. And I got to meet these individuals. And after spending a whole week with them, by the time Friday came, there was a light in their eyes. And every one of them, all 66 men had light. They had joy. They had hope. And that hope that was instilled in them because they found out about something good inside of them. And to the point where some of them hadn't talked to their family members. in years. They were calling their family members because finally they had something to talk about, something that was good to talk about. And so that's my thing with the mental health aspect. It is something that I don't keep it a secret. And I come at it on the level of trauma. I take out the label of mental health and just put it up under trauma and make it, just normalize it, make it a human condition. And I just give the love of Christ to them.
Oh, thank you so much. Wow. Where do we start with that? Just hearing your story. I think there was I could see the faces in the room just kind of start to brighten up with the energy that you were bringing, but your sincerity in sharing your story. Just thanking you for that, and the work that you've been doing. So just an encouragement to continue doing that. And we are all in partnership here. Whether or not we're separated in touch with each other, it seems like each of our stories, we all have individual stories that have brought us right to this point. And I do believe that it is leading somewhere, just trusting that process as we all are. So thank you so much for being here, Pastor Senegal. And I'll go ahead and turn it over to, I think it's Reverend Etsuko Mikami. Sorry if I didn't say your name right.
No, you're correct. Okay, good morning, everyone. Thank you so much for having me for such an important session. I'm very honored to be here as a Buddhist minister and to be able to share my appreciation with Dharma. I'm Etsuko Mikame, a Buddhist minister, San Jose Buddhist Church, Betsim. First of all, Buddhist teachings may not provide a direct solution for the disease or depression, but yeah, this is kind of this wisdom and compassion do teach us how we should view our sufferings. So Buddhism is teaching how to be free from our sufferings and to become a Buddha, which was taught by Shakyamuni Buddha over 2,500 years ago in India. Buddha means the awakened one in Sanskrit word, and refers to as the awakened one who transcend everything. On the other hand, we understand that we human beings have sufferings and troubles when we live in this world because we still awakened and don't have any wisdom to see the world as it is. But so in Buddhism, I believe that Buddhism, wisdom, and compassion showed us the approach how to accept our sufferings and how to liberate from sufferings, and his practice and lead us to the true peace. So the very first teaching that Shakyamuni Buddha showed us is called Four Noble Truths and Eightfold Path. First of all, in Four Noble Truths, Shakyamuni Buddha analyzed our suffering and sufferings. In simple terms, Four Noble Truths are what is our problem? What is the cause of the problem? What is the state in which the problem disappears? And what is the path that leads us to the state? So this is what we usually do. When a business is not going well, if you don't first recognize that it is not going well, it will go bankrupt without you knowing it, right? So first you have to recognize that there is a problem, and then you have to recognize what is the cause. And is it bad sales or too many expenses or something like that, right? And once you recognize a cause, you can think about your goals and how to achieve them. And this way we recognize a problem and consider the cause, determine the goals to be reached by solving the cause, and think about how to implement the goal. The Four Noble Truths are like that. The method to eliminate the suffering is very simple. It is just to remove the cause of suffering. What is the cause of suffering? Shakyamuni Buddha teaches that the cause of suffering is not due to anyone else other than me, not due to our bad luck, but due to our own blind passions, such as, so Shakyamuni Buddha teaches that it is the action of mind that creates suffering, starting from our foolishness of not being able to see things as they are, the mind of greed, and the mind that gets angry when things don't go the way it wants them to. Yeah, so this is what everyone have, and this make it like a life difficult. But the extinction of suffering is the attainment, and the extinction of suffering is the attainment of the state of tranquility, the state of Buddha, where blind passion are all eliminated. So in order to attain a state, Shakyamuni Buddha taught us the Eightfold Path, and he taught us 8 different kinds of righteous actions in Buddhist way. They are right understanding by seeing things correctly, right thoughts by thinking correctly, right speech by using right words, right livelihood by doing right deed, making right efforts, right mindfulness, and right concentration. He suggests us to practice those right deeds to see the things as they are. The method is simple, but reaching the goal is actually not simple and easy, because our blind passion we have are in a way, and as long as we live in this world, in this life. But point here is what is a standard for the being right? If we judge things to be right or wrong based on our common sense, stereotypes, our own preferences, our own assumptions, someone else's opinion, or trends that are widespread in the world, we are not seeing the things as they are, right? But with twisted values. Rather, our rightness here in Buddhism is something relative. What are right changes at the time, in the place, and with the person, and is different. And understanding this, the Buddha's wisdom and compassion make us stop here and question our own common sense and review it and look at it correctly and think about it and an act on it. So therefore, Buddhism is not asking a question to someone else. It is asking a question to you, each of us. So Buddhism is about looking ourselves in the mirror of the Buddhism and wisdom and compassion of Buddha, wondering if this is right or not for you, for us. So reflection ourselves in the mirror might sometimes maybe unacceptable or uncool, but Buddha will never abandon us, no matter what kind of person who we are, because Buddha is working for each of us to lead everyone, every living thing to the state of enlightenment and peace. So what I appreciate about Buddha's teaching is that even when we stumble in a life, even when things are out of the control, even when we are abandoned by everyone, we realize that everyone is given an equal chance to reflect upon our own lives and try it again. So this is kind of what we call today mindfulness. So when we look at the world with the wisdom and compassion of Buddha, we can realize that we have been held back the worst common sense, the stereotypes, our own assumptions, and someone else's opinion. And we can release ourselves from those things, so cultivating thoughts, with little more in ease. For example, it is generally not considered a good thing to be sick or to be depressed, but I believe that this is not necessarily true. It is definitely hard, but the experience of being sick and the time we spend worrying about it can be a precious time that allows us to live our lives seriously and become aware of all these important things through things. And through those wisdom and compassion in Buddhism, I believe that we can free ourselves from the values that have constricted us. Our founder Xingdan, our founder of our tradition, Xingdan, told us to acknowledge our limitation and live our lives and see the world, relying on the enlightened value of the Buddha, which do not judge or figure out anything like that. It does not mean that anything will be drastically changed by the Buddhist teaching, but it doesn't mean you. It doesn't make you rich or cure your illness or any such miraculous things. But it will not change your situation. But it will make you aware of important things that you have overlooked, and then expand your inwardly closed mind and remind you to live this life to the fullest and here and now, no matter what the circumstances. So I believe that being able to aware of things that we could not be aware of before means that we can make space in our minds, our hearts, to accept the amount of things. So therefore, this allowed us to accept things in ourselves with an open mind. So Buddha's compassion led us to accept ourselves as okay, even if we are not in an okay state.
Thank you so much.
Yeah.
So thank you for talking about Buddhism and how it applies to kind of working through suffering and maybe developing more compassion with that. Do you have any? Do you have people that come to you with challenges in terms of their mental health, or have you had people that? How do you address that right away? Do you just go straight to your teaching, or do you try to maybe? What's that process like for you?
The first things I always do is listen to the person. What makes the person think like that, or what make the person thinks like that? So yeah, I always ask those kind of things to the person. So, and then try to help those people to make the things simple, as the Shakyamuni Buddha shows us, the Four Noble Truth. What is the cause of suffering? What is the problem? What is the cause of suffering? And what is the goal for you? And then how do we address something like that? So I always try to help them to make the suffering, what they have in their heart, simple. And then
right.
Yeah.
Thank you so much. Yeah. Thank you. So just simplifying things for them. Thank you. So we're going to go into a session for, again, just thanking you for coming and giving us, I just kind of felt like I could just lay back and relax, just listening to you explain all of that. I don't know if anybody felt the same way, but